Steve Dolezal, Sheriff's Office. Like Bob said, thanks for inviting us over. My part of this presentation is going to be relatively short, maybe 5 minutes and then a video. So you're going to get to enjoy Jessica much more throughout this. And for those that may know Jessica, she's pretty high energy and she wants interaction. So if you have questions, please give her that feedback. So we're here to talk about crisis intervention training, and as most of you who have been in the area for a while know that Johnson County, from a law enforcement standpoint, the jail's been overfilled, over capacity. We've had 3 bond issues that have failed. Voters, the threshold's pretty high, we need 60%, and we've failed in the mid-50s for a couple of those under Sheriff Pokravic. So in 2005, we hired a jail alternatives coordinator, and we have been trying to address overcrowding issues in other ways since we couldn't build a jail. One of the things that we know is that jails are the largest housers of the mentally ill, jails and prisons together. And we also know from a law enforcement standpoint that when we deal with subjects with mental health issues, really we don't have a lot of options. And the options tend to be we can either take them to the hospital or we can find some charge to charge them with. And sometimes those aren't the best choices, but we have to deal with them. I often give the example, and maybe some of you all were involved in this, but probably 15 years ago now, a gentleman shows up in a downtown Iowa City business, and the owner calls from that business and says, I got this crazy person in my store, they're causing a problem, I need them out of here. The officer shows up, realizes the subject has mental health issues, convinces them to take him to the University of Iowa Hospital, takes him to the ER, drops him off, problem solved, right? Not exactly. An hour later, the shop owner calls back and says, I thought you took care of this crazy person in my store. They're back. What are you going to do about it? Officer shows up, arrests him for trespass, into the criminal justice system they go. So they don't really address the issues of the mental health concerns that really needs to happen, but that's what we knew as law enforcement. And I know that I have heard from some of the meetings that we have been involved with that fire deals with some of those same issues. Maybe not as a law enforcement, but as firefighters. And we've often heard the adage that 10% of the people use 90% of our resources. So if we're tripping out fire trucks to deal with people with mental health issues, that's not really what our services are designed for. So we feel your frustration and we understand it maybe from a different perspective. So Jessica is hired in about 2007-ish. And starts doing some things with our jail alternatives and drug court, divert people away. And you know, us in the law enforcement aspect, we think, oh, that's great, this is the Hug a Thug program. Really, you're getting people out of jail, we're trying to put them into jail. And that's really sort of not working together, our objectives. We didn't really recognize the fact that there's other things that can be done. And in 2015, very early, Jessica comes to me and says, listen, I've got this idea. It's this program down in San Antonio. It's called Crisis Intervention. They've got this huge, robust system. They've got this diversion system. They've got this homeless shelter. They've got all these things going, and I really need you to read some articles, and we really need to look at this. And, you know, I sort of, poo-pooed her and looked at it because, you know, I'm not one of those guys that's going to work. People need to be in jail. And so she's pretty adamant and pretty bothersome and like
tenacious, I like to say.
I like to say like a chihuahua that's just nipping at my heels. And you know, I often looked at it I was truly a naysayer. And we often get literature sent to us, and maybe some of you in your positions get literature about new training and go to Vegas and go to DC and go to this training, and you know, it's really just no different than what we always do. It's basically, you're firefighters, we're cops, we know what we do, and that's what we do. So finally, after reading some articles and realizing, hey, we're public servants, as you all are too, maybe there's a different way we can look at this, and really it's Jessica that hounded me enough. So we make the decision, we're going to send some some administrators down from the sheriff's office, some officers down from sheriff's office, Corville PD, and we're going to take a look at this program. So I got to tell you, we went down in the spring of 2015, and I watched this program, and I looked at what they had done in Bexar County, Texas, and I said, you know what, we can do things better. And I got into this job to help people, and what I learned about this program is it doesn't compromise people that need to be in the criminal justice system. There are people who need to be in jail. There are people that's psychotic. There's the people that there's nothing you or I are going to be able to do to them that's going to change what they do. But there are people that are just having some issues, whether it's PTSD, whether it's their medication's off, whether something's affected what they're doing, that really don't need to be in the system and are simply clogging it up. So we watched that and realized, hey, we're not compromising officer safety. We're actually not creating more work, we're creating less work because of their robust system, their ability to divert people. For me to have options, tools in my tool bag that besides jail and besides the ER, there are other tools that we can use, and we've got to figure out how we do that here in Iowa City. So with that said, to give you some background, we've got a short 8-minute video here, and I think it's on that next slide, that if we could watch this video, this will give you some background. This will be the point. I'll step aside.
It's one of several police shootings involving people with mental illness.
18-year-old Keith Vidal struggled with schizophrenia. He wasn't violent, and all they wanted was help getting him to treatment. Seconds later, the officer shot and killed him.
They murdered our son for no reason.
Another disturbing video that raises questions about the treatment of the mentally ill behind bars.
He would hear voices.
The extraction team restrained him. Minutes later, the 33-year-old was dead.
Jails are the #1 mental health facilities across the country. They house more mentally ill person versus any hospital, any psych facilities, anything. They're patients, not prisoners.
Mental illness is the only disease that when you're in a crisis, the cops are called. If you're having a heart attack, you don't call the police.
People with mental illness are being criminalized instead of being provided treatment.
These county jails and law enforcement, that's a public safety net. That's where you end up.
There has to be some sort of solution, some sort of help for people who are suffering from mental illness and become involved with the police.
Jeff was the youngest of our 4. He was finally diagnosed a paranoid schizophrenic. When he was totally out of control and very frightening, I would have to call the police on him. They didn't know what to do.
I would get calls all the time when I was on patrol for a person who was in a mental health crisis. I had no clue how to handle it. And I would just keep getting the repeat calls every couple days or every week to the same house, the same person. And I just accepted it that, this person's just going to be a repeat caller.
We decided very early on that we needed to address folks that were nonviolent misdemeanor offenders that were truly being put in jail because of their illness. We knew that it was law enforcement that were first responders and that they would be the ones that would be in contact with individuals in crisis.
So we decided what we would do first is train law enforcement officers in the 40-hour crisis intervention training. So they're trained to recognize mental illness. When they come up on somebody that's got kind of strange behavior, they're not using their command voice and the command presence like they're taught in the academy. They realize right away that this person has a problem. We brought together a bunch of law enforcement officers from the sheriff and the San Antonio Police Department, and every one of them didn't want to be there. I heard things like, I'm a cop, I'm not a social worker, I don't believe in these hug-a-thug programs, and this is a bunch of BS.
Before I went through the 40-hour CIT training myself, I didn't have the resources on how to handle mental illness. Well, now, it's way different. You know, I have confidence that when I go into someone's home, if they are experiencing some type of, mental health crisis, that I can get them to the right facility, and then I may never hear from them again.
I'm a mother, I'm a sister, I'm a friend, I'm a voter, I'm a volunteer, I'm all these people. I contribute to my community, and I have a mental illness. My diagnosis is major depression with psychotic features. dissociative identity disorder, and panic disorders. I've done the presentations to CIT Training. And I tell them, I want to be treated the way you want your mother to be treated if she was ever diagnosed with a mental illness. I'm in a crisis, I'm having a crisis, and I don't understand what's going on around me.
Get back! Get back! Get down! Don't do it! Don't do it!
In incidents with people who have mental health issues, it's unfortunate to see the ones that result in the use of deadly force where an officer didn't have CIT training and possibly armed with that kind of information, that kind of training, outcomes may have been different.
I never knew each morning when I got up what I might find. He began to talk about a fire in the garage. So I thought, would he, without knowing what he's doing, start a fire? How much danger is he in, and how much danger am I in? So I called the police and I said, I'm terribly frightened. When they arrived, I introduced them to Jeff, and in this case, they came in plain clothing. They weren't in police uniforms. Now, they could have handcuffed him, I guess, and pulled him out, but they are taught how different that person is that they're dealing with. So they began to talk to Jeff. If they can get the person that's ill to, in their own mind, they're cooperating, is far less violent. It's better for the patient, and certainly it's better for our police.
When nonviolent people go to jail with mental illness, they stay 3 or 4 times longer than a violent offender. But when they get released, if they're not hooked up into treatment, they're going to be right back in. There are so many people in their emergency rooms who shouldn't be there. The previous police chief here has actually kept data on how long his officers are spending in emergency rooms waiting for psych evals and medical clearance, 8 to 14 hours. He spent $600,000 a year in overtime. Now here at the Restoration Center, the law enforcement officers are in and out within 15 minutes.
What we have here at the Restoration Center is services patients who are in crisis. They either walk in or brought in here by CIT. They recognize the patient's in crisis. They're not truly suicidal. They don't really want to hurt somebody. They just need help.
There are about 18,000 people a year who are brought mainly by law enforcement officers to this Restoration Center who used to go to jail or emergency rooms or put back on the street. If you're a taxpayer and really don't know a lot about mental illness, the fact that the public's a lot safer when these people get treated, and the taxpayer saves a ton of money. Over the last 5 years, we've saved about $50 million in taxpayers' dollars.
We want everyone trained because of the potential daily that someone's going to come across someone who's in crisis. It's not a matter of if, it's a matter of how soon.
We've been coming up on 6 years of existence, and we don't have a use of force on our unit, which means we've never tased anybody, we've never shot anybody, we've never hit anybody with an asp. But patients, talking to them, we get the result we want in the end, and we don't have to force it on them.
You want CIT to respond because you're going to get the help that you need rather than be sent to jail.
The issues that police officers have with people who have mental illness is not unique to San Antonio. That's all over the country, all over the world. So any city that would decide to focus on this, put an emphasis on this, would certainly benefit from it.
I no longer thought, what if they have to shoot Jeff?
We save money, we improve public safety, and people can get functional again. I mean, why wouldn't you do this? It's really a no-brainer.
I like that he answered that. Why wouldn't you do this? So flash forward, we're going to do this in Johnson County. So the remainder of the time we're going to talk about kind of what CIT is, what we're going to be doing in Johnson County, and if we have time, let's just kind of a little preview of what the 40-hour training looks like. So when I started here about 10 years ago, I like to say that because I feel like a real life adult. Like I've worked in the same job for almost double digits, and that makes me feel like an adult. So when I first started, I came here, NAMI, which is National Alliance of Mental Illness, NAMI Johnson County was like, we need CIT, we need crisis intervention team training, tell the chiefs that we'll write grants, we'll get you money to put this on. And at the time, chiefs were like, that's 40 hours, that's 40 hours I'm taking my people off the streets, that's OT, like I can't afford this, I can't do it. Now flash forward 10 years, and not only are the chiefs like, yeah, we can do that, but we can even pay some people to go down to San Antonio. I can pay my officers to go down there to get trained to do the instruction that we're going to do here locally. And a lot of that is because of the benefits. Like Steve didn't mention the part about how he went down there and like drank the Kool-Aid. He started out as a naysayer, but he's a convert now. And a lot of it is because of the benefits. And when I first started working in jail alternatives and we were doing the post-booking side, and you know people have been arrested, they're in jail. Now my job is to go and assess them and get them into services and get them out. And they would call me the bunny hugger. I was like, not even a tree hugger, like I was the bunny hugger. Like going in, it's this hug and thug thing. And that was true, but also there's value to them, right? We used to have about 180 was our daily sentences in our jail, which is a 92-bed jail. So we're housing all people out of county. Now our average census is somewhere right under 100, right? So if we get people out, we get them in services. One of the benefits that they talk about in here is you don't have those repeat calls. You don't have those people coming back. If you can identify them, get them plugged into services, you're not using really high cost interventions that have poor outcomes. So that's one of the benefits. So when we start talking to officers and chiefs and fire about what in fire and EMS, you know, what is this going to do? Not just because it's kind of the right thing to do, it makes us feel warm and fuzzy, we're helping people, but there's also a lot of benefit to the bottom line. And I won't go through all of these, but improved officer safety is one that they talk about a lot. With CIT, there's a lot of verbal de-escalation that happens, and you're aware of signs and symptoms, so you kind of know what you're dealing with. So it increases voluntary compliance, right? So going hands-on goes down. When IMCC, the Iowa Medical and Classification Center, started doing a modified version of CIT in I think like 2011, and in the first 6 months of doing it with all of their correctional officers and such, their use of force went down 50% on their forensic psych unit. So that means you're gaining voluntary compliance. You don't have to pay workers' comp because people are getting hurt because they're going hands-on. So we like to hit the dollars and cents because that's important to any municipality budget. Decrease repeat encounters, I mentioned. Improve community relations. I mean, I get you guys are firefighters, so you probably don't need that as much. Everybody sort of likes the heroes. For law enforcement, that's really important, especially with the political climate these days. That's something that this does improve community relations. The former city manager, Tom Marcus, was down with us on one of the trips to San Antonio, and he sat through the first day like Major Delazal did, and he said it's a paradigm shift, right? It's a whole different community and customer relationship that develops among law enforcement. So it increases community partnerships. It just changes the face of how we talk about community policing, and this kind of gets at the kind of concrete and tangible aspects of doing that. Reduce costs, we kind of mentioned that, and then increase access to behavioral health care. I like to mention this because 1/3 of people with mental health and substance use disorders are going to come into contact with law enforcement before they do the behavioral health system. And I would imagine that's also applicable to fire and EMS. Any first responder, while you guys may not have signed up, you didn't sign up to this to be a frontline behavioral health interventionist, but those of you who are first responders are going to see people with mental health needs way before we as clinicians are going to see it. So you guys have the opportunity from a public health standpoint to get people, you guys are dealing with their medical stuff and you guys are EMTs, right? You're also making sure the houses don't burn down, those kinds of things. But you also have the opportunity to get from a public health standpoint, get people plugged into the services that will help them get their needs met, create community wellness, and also maybe prevent some of those repeat calls for service that Major Dolezal touched on. I heard there was a recent roundtable that you guys were involved in some of those calls for service, that the repeated ones, and often with like the elderly population and aging population, that it's not really a fire situation, but they're calling over and over because they have other needs that they don't know what to do with call 911. Yeah. So a lot of times, if anybody's ever heard of CIT, they think of the 40-hour law enforcement training. So, and even Leon, even in the video it says CIT Crisis Intervention Training. CIT actually stands for Crisis Intervention Team. The 40-hour training is one piece of it. So whenever I talk about CIT programming, I like to bring a little 5-legged stool. One of the Police Chiefs Associations put out an article that very succinctly outlined what CIT is. And the 40-hour training is one piece of it. But community collaboration is huge. So when we talk about CIT, and we can train officers and first responders in verbal de-escalation. We can train them on what signs and symptoms of the primary mental illnesses and substance use disorders are going to look like, and we can talk about some community resources. But we don't have that community collaboration where we're building up the community resources that are available. We're making it law enforcement friendly and first responder friendly, meaning you don't have to sit in the ER for 4 hours. That restoration center that they talked about in the video, the average time is 10 minutes. First responders are in and out in 10 minutes, which is huge for those who have to sit in the ER for 4 to 6 hours. They know that that's not typically the way we do things. So community collaboration is key. If we, in places where we currently don't have a restoration center, this 24-hour friendly drop-off where you have sobering unit, detox, crisis observation, crisis stabilization, essentially a behavioral health ER. We don't have that right now. So we have a lot of community collaboration though about how can we bring the pieces that we do have in place and help partner with our first responders in a way that makes their job easier and gets the people's needs met. A vibrant and accessible crisis system. A lot of communities that start doing the 40-hour training, the chiefs are like, right away, my office, I can train them in this, and right away they're like, okay, but divert to what? Right? Yeah, I get it, this person is not a criminal, they have a mental health issue, and what do I do with them? Like Steve mentioned, you know, you leave them where they are, take them to the hospital or take them to jail. So it's very, very important that we start developing better crisis services. So you probably saw in the paper, you know, we're in the process of looking at in our ideal world, but we would like to see some of the things that we saw down in San Antonio. We'd like to have a campus-style place where we have a sobering unit, detox, crisis observation, some type of crisis stabilization, and low barrier shelter. For you guys may or may not know, since we started the winter shelter, the low barrier shelter where you can go and you can be intoxicated, there was an 80% reduction in vagrancy calls for service. So some of those lower level offenses, we saw a lot fewer calls for service in that. So there was, this community said, we need to do this. So we're looking at doing this, and there was a lot of forward momentum. It was in the paper, and then we had to talk about how to fund it, and it was like we've slowed down a lot. So we're trying to work on funding for that piece of it. But you can't really talk about CIT, you can't have a program, you can train your officers, but you've got to also have the crisis service available, so we're working on that. Behavioral health staff training. A lot of times when we think about how do we keep people with mental illness and substance use disorders out of the criminal justice system, we think we have to train law enforcement, we have to train prosecutors and judges, and we have to train our behavioral health system, right? Like the number of times I make referrals from the jail side, from the post-booking side, to providers that are like, yeah, justice involved, like that's a lot of complicated, you got addictions going on, that's complicated. When we have a lot of other people who like really, really want to be here and they're kind of not behavioral problems, those are easier to serve. So it does require kind of that partnership with behavioral health and educating them on even what this system is. There's people that they get upset that, you know, this person is actively on suicide watch and they discharged them from jail to the street where they're actively suicidal. I was like, well, there's this thing called like civil liberties, and if the judge said, you know, somebody's like not in custody anymore, they can't just keep them, right? So they can problem solve. Like, okay, if that's the case, the jail can call mobile crisis, and we'll talk about mobile crisis shortly. But mobile crisis could call mobile crisis. Behavioral health professionals could come. So that, again, that community collaboration, training all the first touches is important. And then, of course, the last one is family consumers or clients, people with lived experience, whatever word we want to use there, advocates to collaborate and educate. So it's very, very important to have people with lived experience, people who are utilizing the services involved in this. And that's what we're doing in Johnson County. And I don't know exactly what the next slide is. So we'll talk about, so flash forward, we've been talking about this since May of 2015 was the first time we went down to San Antonio. At the time, we didn't really even know what was going to come of it. But when we came back in, I think it was February of 2016, we had a community conversation, and we had board of supervisors, mayors of the, you know, many of the communities in Johnson County, chiefs of police, community providers. We all came together and said, we definitely want to do the 40-hour training. So we're going to do 3 a year. The first one will be March 20th through the 24th. So at least one of you from Fire will be there. We're going to do, there will be 64 participants in each training, and that will include all 6 law enforcement agencies in Johnson County and Fire and EMS. So that was a big, from the very beginning, all the decision makers and elected officials said we want to have all of our first responders get trained in this. And CIT International and CIT Memphis, which is where CIT started, was in Memphis, Tennessee. they would say, if you can do nothing else, you want to train at least 25% of your force. But our chiefs have said, we want everyone to go through. We want everyone, so like San Antonio was talking about, everybody's going to encounter this. We want everyone to have some training and experience in this. So St. Pat's Church in March, we're going to do this, and then 3 times a year in March, May, and October. And to show this is our agenda for the 40-hour training. And the reason I put it up here, it is color-coded, which tells you how sort of OCD I am, but it's purposeful. The ones that are highlighted in green, those are all law enforcement first responders. So the thing that's sort of unique about crisis intervention team training is that it is people on the street, people in the fields who are talking to each other about behavioral health and how to interact with people with mental illness and talking about mental illness and substance use disorders. So on Monday, you can see most of the people presenting are officers. And then throughout the week, we sort of sprinkle in clinicians and doctors and such. And when possible, we try to co-present with, if we're using a clinician, and we can also have a first responder or law enforcement co-presenting to say, yeah, they're talking about all the gray matter, talking about the brain stuff, and this is what it looks like out on the street. This is what I encountered last week on a call for service. So that's kind of the unique thing, and I think that when I've been down in San Antonio, I've seen that. It seems to me that's what people really respond to. I went to one CIT training where there was more clinician instruction and less of the officer, and it had a different feel. And so I think this was very important to us to have law enforcement involved. So when you come through this training in March, May, and October, you'll see it'll be a lot of people in uniform, a lot of officers, and Bob will be presenting. We have EMS presenting as well. Fiona Johnson will be participating. And so that's sort of a unique thing about the 40-hour training. So this just outlines, all the different categories. I will tell you that, for the most part, I'm sure many of you see this all the time, but for the most part, we cover a lot of the diagnostic categories that you're going to see a lot of, mania, suicide, depression, PTSD. We do include intellectual disorders. I think Bob was talking about somebody presenting on autism spectrum, so we'll have somebody talking about autism, intellectual disabilities, and then we bring in people with lived experience. So one of the things, and Bob would have experienced this down in San Antonio, and we're going to do this here, that we bring in somebody with an intellectual disorder and you just open it up to the audience and say, have a conversation. So you learn very quickly, like, the way that I might typically ask this question might not get the answer, might not get an answer. I'm going to have to learn, how can I talk to people experiencing different cognitive disorders or mental illnesses or symptoms? How might I have to change my questions a little bit so that I can actually get some information. And when we bring in the people with lived experience, that provides people the opportunity to know, like, when somebody is not, responding quickly, or maybe they're not giving you an answer that makes sense, it's not just necessarily non-compliance, right? It might be that they don't understand the question, or they're hearing a bunch of different voices in their head, and they have to take some time to think about, is that a voice in my head, or are you asking me a question, and I got to process through all of these things. So we do take some time to bring in people with lived experience, so officers and first responders can have a in-person experience with that. And then we do a lot of scenario-based exercises, also known as role plays. Every day you have an opportunity to practice the skills that are being taught. And I know, at least for law enforcement, maybe fire is different. Usually we say role plays and they're all like, peace out, I'm gone. Like, that is not something I want anything to do with. But the way they do it, at least in San Antonio, I thought was done really well. You break up into small groups, read the same group every day, and you go through the various role plays so it doesn't feel quite as uncomfortable to practice the skills. And I will tell you, I've had the opportunity to kind of observe Monday to Friday, and in the front, I don't know about fire so much, but with law enforcement, on day one, they're like, type it, like, I want a disposition. Like, I'm going in there, I just want to have a solution, and we're fixing this. And in the beginning, you're just learning rapport building. How do I use some active listening, communication skills? So I always think about, this might sound a little pejorative, but on day one, it always it was like sort of like a dog on a leash. Like, the facilitators are all like, no, back up. You're not saying, where are we going? Can we get you, doctor? Like, you're saying, like, hi, my name is Officer Joe. What's your name? What's going on? Tell me, how can I help? I'm hearing you say this, and oh, that sounds upsetting. They're just practicing their active listening skills and not even getting to a disposition. So it's fun to watch. Well, for me, because I'm kind of a behavioral health nerd, it was fun to watch from first day of the week and then Friday to see the shift in how officers are approaching these different situations. Yes, Bob.
Just one thing about the role play deal, and I realize that gives everybody a certain amount of trepidation, but the best part about that isn't the 7 minutes that you have to stand there and interview somebody, okay, as I did it. The best part of that is the 7 minutes where you get to watch somebody else do it, and you think about the questions that you would ask in that situation, and you get to see how formulating the question gets the response, and how you would maybe have asked it differently, and how it goes from there. So even though you're only doing it for 7 minutes out of this entire afternoon, what you can take away from that, if you really do pay close attention and follow it along that way, is a lot of skills in communicating with these different things. The role plays all go to the stuff that you spent time on during the day. They're all, so if you spent the morning talking about autism spectrum folks, you'll have a role play with one of those fellas, or any of the other mental illnesses. So you can really start to identify people in that particular thing, because the actors are well coached and well trained on what they're doing. It's just not it's time well spent in that, both in the preparation. But you'll get 15 or 20 different evolutions every day through these different things, and get to see how your questioning and how you approach them can affect that. And that's what really makes the thing sink in. So even though you might be nervous about going up and doing some of that stuff, the behind the scenes stuff that does it, to me, is just as important or more important than the actual what you're doing while you're doing it. Does that make sense?
Yeah, no, that's a very good point, because I would find even I was mostly just an observer down there, and that's exactly what I would be doing. Like, oh, that type of question. And there's something things, and I'm a licensed clinician. Like, I have my master's degree. I have done psychotherapy, and I sitting in the audience. I remember thinking there was a time that they were, or maybe it was a time that they had me be a role player because somebody didn't show up, which should not happen here, or I might have to call you guys to come, give me a AED. But I was being the role player, and I remember they were saying something to me, like asking me like what my diagnosis was and what my issues were, and I was like, why is it like I'm not having this issue because I'm mentally ill? Like, I'm having an issue because something's happening. So even from that, I was like, whoa, that the things that we're kind of trained to do, and we ask these questions all the time. I mean, how many times do you ask, like, well, what medications are you on? Are you seeing a doctor? What's your diagnosis? Like, it was really invalidating. Like, no, this is not what the issue is. Like, tell me that you're here to help me, see what's going on. And I was like, I was thinking, I should have probably known that, so it was very valuable. And the other thing I would say is, I won't identify which chief it was, but a chief was sitting next to me as we were observing, and because he was listening and watching, he's like, oh no, this is the way, he's like whispering in my ear, like, oh, he should be asking this. This is really the question, and that's exactly right. That's the learning that happens when you get over the discomfort of, I have to stand up and, do things in front of people that you do all the time. A small group, it's like 8 people, and we all, you all do it all the time. This is not, they're not asking you to do skills that you've never done, but it's uncomfortable people are watching. I'll just read you, Crisis Intervention Team is a first responder model of law enforcement-based crisis intervention with community healthcare, consumers, advocacy, and partnerships. And that, it's often referred to as the Memphis model. I know we've talked about this, but I don't think you can underemphasize that this is a collaboration. And in Johnson County, it was very clear that we wanted all the law enforcement agencies. So the people who will be doing the instruction are, Johnson County EMS will have an instructor, Iowa City Fire, Coralville PD, North Liberty PD, University of Iowa PD, Johnson County Sheriff's Office, Iowa City PD. They've all sent officers and deputies down to Johnson County. So it really will be across system, across agency collaboration, and then we have lots of community providers, the mental health center, the university, various providers all coming together, because the mantra of CIT is that it's law enforcement led, community supported, and that's really what we're trying to model here. So the thing that we like to tell officers is that when you go through this training, you're not going to become a therapist, you're not going to become a doctor. So you can play this short video real quick.
Could switching to Geico really save you 15% or more on car insurance? Does a former drill sergeant make a terrible therapist?
And that's why yellow makes me sad, I think.
That's interesting. You know what makes me sad? You do! Maybe we should chug on over to Mamby-Pamby land, where maybe we can find some self-confidence for you, you jackwagon! Tissue? Cry, baby.
Geico. 15 minutes could save you 15% or more.
Right. So, the point is that because when you see the slides for CIT, like you will always see, like, never forego your training. Like, never, you always have your cover officer, safety first, and obviously it's a little different for fire and EMS. But the point is, we're not asking you to stop being what you are. You know, you're fire, you're EMS, you're law enforcement. So you're not going to be a trained, you're not going to become a psychotherapist, and maybe for good reason. But you will learn some new skills perhaps, and just gain some awareness. So this is just some information. Earlier I talked about mobile crisis outreach. So we talk about, you know, on the five-legged stool, having community collaboration and crisis services. We don't necessarily have, we don't have the law enforcement friendly drop-off center, but we do have mobile crisis outreach. And that started about, I think it was February of 2015, we just got it. And if you guys don't know about it, I will get you more, I can get information to Bob. And for the CIT officers, this is really their go-to tool in terms of, you know, if they need a disposition, if they can't leave the person where they are, this is the number they're going to call. So mobile crisis outreach it's 24/7. They have two mental health professionals on call 24/7. So they will respond on scene. If you call, they will come to a person's home, they'll meet somebody at the hospital, they'll meet wherever they're at. The mental health professionals are going to come on scene. There are a couple caveats. They have to be, you know, quote, voluntary. I mean, the person has to say, I'm willing to talk to somebody else. There are some communities where you have like a law enforcement behavioral co-responder, and the person may not be voluntary at all. You're just showing up on scene. And the version that we have here is that they have to be willing to talk to somebody. They have to say, this is something I want to do. There can't be any weapons on, you know, if they have a gun closet and they're locked up, that's fine, but they can't have any weapons out and using them. And they can't have already attempted suicide if they need medical intervention, But if it's anything, you know, if somebody's intoxicated or they're feeling suicidal but probably don't need a hospitalization, and they're willing to talk to somebody and they're saying, you know, I'm kind of willing to contact for safety, but just need somebody to talk to. Two behavioral health professionals will come on scene. And the other nice thing that I don't want to underemphasize is that they'll provide follow-up care. So if I have contact with mobile crisis today, within 24 hours I'm going to get a follow-up call. So this really starts to help with that preventive repeat calls for service, because they're going to have somebody who's following up saying, oh, you needed to get medication. Here's the appointment. I'm going to help you make the appointment. Did you make that appointment? They're probably going to call and say, hey, you have a psych appointment tomorrow. Do you have transportation? Are you able to get there? So mobile crisis is your friend. If you're not aware of this, that's something that can be used. And this is just a little situational awareness, contextual information. The mobile crisis team that we have is through our mental health region. You guys may or may not know, we are within a 9-county mental health region. And so they serve all of those counties there. We do have a team actually in Johnson County that serves Iowa and Johnson County. So they say that response time has to be within an hour. Typically, if it's happening in Iowa City, it's going to be closer to 20 minutes because most of our counselors are actually physically here. And the number that I have on here, so you'll notice there are two different numbers. The general public has this first number, and law enforcement has a special number. So we worked very closely with the region to say this is not a very law enforcement friendly way of doing it. So I made it clear that all the first responders are going to be getting this number, so you guys can technically call this number. They'll know that it's a first responder. They're going to ask you very minimal questions. Where's the location? Is the person willing to talk to somebody, and are there weapons? And then they'll connect you directly to the mobile crisis counselor, and you can tell them what's going on, and they can kind of ask a few questions. They'll show up on scene. And then take over from there. And then I include this number, and if you guys don't already have, do you guys have some of the hotline numbers? Yeah. Because that's important, because I always say the officers, start to give the family members or whoever called, give them that number so that this is part of the whole CIT model and the community and public education is when we start to get more resource information out to the general public, then maybe the next time this is coming, they don't have to call fire, they don't have to call EMS or law enforcement. They'll say, okay, if this is a behavioral health crisis, rather than calling 911, I'm going to call the Iowa helpline. So that's what we're really trying to start training the public, is that let's move away. We've been trained to call 911 for every emergency, but if it's a behavioral health emergency, we want them to call the hotline. I'm just blazing through stuff. Do you guys have any questions?
To see if you've encountered the JCOM, and as far as dispatching, getting them involved as far as all of this, because they play a critical part of this, right from the get-go as far as gathering information and everything else.
Yes. Good question. Yes, no, that's a great question. So yes, we've had conversations with dispatch, and in communities that have CIT, they will often have a separate CIT training. Instead of having the dispatchers go through a 40-hour training, they'll do an 8 to 16-hour training. So we're trying to figure out what that's going to look like in Johnson County, but we've talked with Tom Jones and Brandon Siggins out at the JEC, and they've both been involved in the planning conversations. They're going to be, so yes, dispatch is going to be involved. They'll be involved in the training. We're trying to figure out if they'll have a separate training or if they'll come to the 40-hour training. And right now, when officers are called out for CIT calls, they call dispatch back to code it in that way. So dispatch is already becoming aware of this, but the point is exactly well made that the dispatchers need to be trained because they're the first ones who should be screening to see, is this a behavioral health call? And they can know, I need to make sure that I communicate. If we have a CIT officer available, they need to be the ones responding. So I'm going to go through this stuff pretty quickly, especially since fire this is probably not new to fire. You guys are typically not securing the scene. You're doing things to try to see what services what service you need to provide for people who are you're responding to. So, but what we talk about with law enforcement is we're trying to switch the conversation from command, tell, force, do, and dispose of it, but to actually using some active listening skills. So I'm going to jump into that, to active listening skills.
You will each be required to answer an actual 911 call. All right, there's one now. Cadet, you're up.
I think there's someone in my house.
Oh, I envy that. I live alone. Nobody ever comes over my house.
No, there's someone in my house right now.
Well, maybe you want to put out some snacks or something. Doesn't have to be nothing fancy. You can even just open up a box of Wheat Thins, pour some in a bowl. Multigrain's always good.
Oh my God, they're coming up the stairs.
Oh, you're going to have to close that bedroom door if your bed's not made. Maybe perhaps you could put on a video later and sneak upstairs and make that bed. Oh, looks like they saw that bedroom.
This is the crux of what the de-escalation is. We talk about active listening. And again, these are not communication skills that you don't already use, but they give you kind of a nice acronym to use. MORE-PI, which is easy to remember, but these are the skills you're going to be using when you're doing role plays. We're going to practice MORE-PI, which is minimal encouragers. You all know that when you're saying, yeah, tell me more. Open-ended questions. So often we ask people yes or no questions, closed-ended questions. You're not going to get a lot of information. And what we talk about with CIT and with de-escalation and active listening is that you're really trying to get information. So if you spend an hour on a call for service and you've just been telling them what to do and asking yes or no questions, you have no information to pass on to the mobile crisis counselors or to the doctor. So the active listening is to get people to calm down, build rapport, and to try to gather information. So you're asking open-ended questions, reflective mirroring, and so you're repeating back what you hear them say. So again, they feel heard, and it gives them an opportunity to clarify. Like, no, that's not exactly what I was saying. This is really the point that I'm trying to make. Effective pauses. This is really uncomfortable, even for clinicians. A lot of times we want to fill the silence, but if you, especially if somebody's experiencing psychosis, giving them a pause so that they can hear what's being said, process a response, and get back. When someone's in crisis, you all probably know this, as anxiety and crisis goes up, our cognitive thinking skills go down, so it's going to take a lot longer to get responses, so effective pauses are really important. Paraphrasing is similar to reflective mirroring, repeating back what you said. I statements is really important. We practice these at the sheriff's office sometimes using our I statements. Because I statements, it doesn't feel threatening, like you need to calm down, you're upset, and instead of saying, I'm concerned about what's happening here because I want to make sure that you're safe when I leave. Rather than telling them that they're doing something wrong or that they're causing something, you're saying, this is how I'm experiencing this. I'm worried and I want to figure out how I can help. And then emotional labeling. Again, this gives them an opportunity. If you say, like, you appear to be upset, you appear angry, you appear sad, that helps them, again, identify their emotions and calm down a little bit and be able to say, yes, this is what's going on, this is what I'm feeling. So this, I'm going through this really quickly because you guys probably know a lot of this, and this will get hit heavy in the 40-hour training, but this is really kind of the boiled down, simple version of this is the de-escalation skills that we're asking people to use and that you're going to use a lot during the role plays. And this is just to highlight that through active listening, clients will often tell you what has worked for them in the past and reveals a solution to their immediate problem. So again, a lot of times when you're experiencing people in crisis, this isn't the first time they've ever had this, and likely it's been resolved effectively in the past, and there are times that it hasn't been resolved effectively. So through active listening, asking open-ended questions, we can find out when has this happened before, what was helpful, what was not helpful. Let them give you information, helps your job a little bit easier, and it helps them get the solutions that they need.
first ever prescription depressant hit the shelves today. Approved by the FDA last month, Despondex is intended as a treatment for the approximately 20 million Americans who are insufferably cheery. Tests prove the drug is effective at reducing a range of symptoms, from squealing loudly when a friend calls to use of the phrase cool beans and excessive hugging. Dr. Alman Way calls the drug a huge step forward in the battle against exuberance.
If you're in a good mood every so often, well, that's fine. That's normal. This is for those that have a persistent positive outlook on life.
Eva Hendry of New Haven, Connecticut began participating in a clinical trial of Despondex 6 weeks ago.
I was always telling people how cute their outfits were and bringing them little gifts. I'd beam at anyone who made eye contact with me. I didn't realize life didn't have to be like that.
Eva said she never knew how her annoyingly chipper attitude was affecting those around her.
Over and over again, I'd ask Jeff to ride his bike down to the botanical garden with me. No matter how many times he said no.
And she was always smiling, but I didn't know what to do to help her.
I used to think, why am I the only one trying to set up single friends with each other? And now I realize it. I was sick. I needed treatment.
Eva says the drug may have saved their marriage.
Now Jeff and I can just waste a night sitting on the couch, watching a TV show neither of us enjoy. Like a regular couple.
Not everyone is convinced that Despondex is the cure-all for perkiness, however. In this week's Time magazine, Michael Polosik of UCLA argues that many patients get similar results from natural remedies, something as simple as a diet of corn syrup and white bread and a total lack of exercise. But Dr. Way disagrees.
We have to erase the stigma attached with getting chirpy people help, real medical help. I mean, do you know what it's like to be around these people? It's pretty fucking annoying.
Doctors estimate the new drug could reduce the number of costume or theme parties in the U.S. by up to 40%.